Hello everyone. Today we are going to discuss interstitial lung disease. So when we say interstitial lung disease, you need to know that we are discussing about this particular space between the alveoli and the capillaries. So what are the things that are involved in interstitial lung disease? Is the number one is that this alveolar epithelium is involved. This alveolar basement membrane is involved. This space is involved, plus the capillary endothelial is involved. So what happens in interstitial lung disease is that there is formation of a scar, or there will be formation of a granuloma. You need to know that there can be granuloma, there can be scar, and this granuloma can also progress to scarring of the tissues. So this scarring that is produced here, we call it as a fibrosis. So there are different type of classification when you will understand interstitial lung disease, but my request to all the students who are watching this video is that you always follow the textbooks, the standard textbooks. The best classification that I got it from is the Harrison's Internal Medicine. So in the Harrison's Internal Medicine, it is being said that the interstitial lung disease is classified as number one is granulomatous interstitial lung disease, or interstitial lung disease due to fibrosis or scarring or inflammation. So they have divided into two parts. So we'll discuss that thing in the later part of the video. So first we need to know the pathophysiology. So what happens here? What happens here that leads to scarring, or what happens here that leads to formation of a granuloma? So we need to know this is a restrictive lung disorder. So when there is a development of any scarring here, so this space will be lost, and so there will be difficulty in breathing or difficulty in expansion of the thing. So let's understand the pathophysiology first. So let's start with, you have to know that there are many different causes of interstitial lung disease. Pneumoconiosis is one thing, there will be dust, and smoking is another thing. So let's assume that this person has taken a lot of smoke. So when, because of smoking or any sort of dust particles, when they are repeatedly coming into the alveoli, what is the first thing that happen? First thing that happen, or you will write in the exam, is number one, it's a micro-injury. Micro-injury to epithelium. That's the first thing happens. So repeated exposure to dust, organic dust or inorganic dust or smoking, it can lead to some alveolar epithelial damage, which is called as micro-injury to epithelium, alveolar epithelium. So once there is injury here, this epithelium is damaged, then the inflammation process actually it starts when the alveolar epithelium damage. Because once the alveolar epithelium damage, then what they will do, they will create a antifibrinolytic environment. Okay, you can say antifibrinolytic environment. So there will be creation of an antifibrinolytic environment. Means what? This wounded alveolar epithelial cells, they will produce lots and lots of this plasminogen activator inhibitor. This is called plasminogen activator inhibitor. Plasminogen activator inhibitor. Type 1 or type 2. Okay. So as the name suggests, plasminogen, what this plasminogen do? This plasminogen is converted into plasmin and they clear the clots. So now when this plasminogen activator inhibitor, we are inhibiting this plasminogen activator, then what will happen? There will be formation of many here multiple clots. So this is called antifibrinolytic environment. So there will be creation of an antifibrinolytic environment which leads to formation of multiple clots here. So this is one thing that happens here. There will be multiple wounded clots here. Plus what happens? This wounded or this damaged alveolar epithelium, what they will release? They will release some growth factors here. They will release growth factors like tumor necrosis factor alpha, transformation growth factor TGF-β, and they can also platelet derived growth factor. So these are the growth factors. So once they are released into the space, into the interstitial space or into this environment. So what will happen? These are growth factors. So what will happen? These fibroblasts that are lying here. So this fibroblast. So the fibroblasts here, they will migrate and they will proliferate. So now what will happen? There will be migration of the fibroblast. They will migrate and they will proliferate. So the fibroblast from here, they will migrate and they will also proliferate. So they will migrate and they will proliferate. This is the next thing happens in development of interstitial lung disease. So there is now these fibroblasts from this alveolar basement membrane, they are migrating and they are also proliferating. In the meantime, there is some more addition of some inflammatory factors that now there is some release of some other factors like gelatinases. Gelatinases A or B. So what these gelatinases do? They destroy this basement membrane. So once the gelatinases A or B, they come into the scenario and they destroy this basement membrane. So what will happen? There will be more and more fibroblast migration. So as a result now, some more fibroblasts are migrated. Now what happens next? So once this fibroblast is migrated here, because of these things, now we need one more thing here. We need some supply of basic nutrition here so that this can grow. So for that we need vascularization, we need neovascularization, we need some new blood vessels to settle here. So next thing is that once the fibroblasts start migrating and proliferating, number 4 is that there is neovascularization. Neovascularization, or you can say angiogenesis. So now it starts with neovascularization, or you say angiogenesis starts. Now how this neovascularization angiogenesis starts? So to develop any new blood vessels, whether it is in the lungs or in the heart, whenever any artery is blocked, there is some development of some collaterals to bypass the blocked area. So to anywhere in the body, whenever there is a need to develop a new blood vessel, so there are two factors that are very important in this thing. One is called metalloproteinase enzyme, MMP. So this is called metalloproteinase enzyme. Metalloproteinase enzyme, MMP. Number 1. Another factor we need is that tissue inhibitor metalloproteinase enzyme. This is called TIMP, tissue inhibitor. So this MMP, what they do, they promote angiogenesis. So this MMP, when there is enough MMP, they always promote. And to neutralize that, to counteract this tissue inhibitor metalloproteinase enzyme, they always inhibit this metalloproteinase, they inhibit. So in our body there is a balance, there is a balance that exists between this tissue inhibitor metalloproteinase and metalloproteinase enzyme. There is a proper balance so that angiogenesis is maintained whenever and at a normal level, and it is only occurs whenever our body needs it. So here what happens, when these things are growing, when this inflammation process has started, what happens here? This balance between the tissue inhibitor metalloproteinase and this MMP metalloproteinase enzyme, this balance is lost. So now, as a result, this metalloproteinase enzyme, they take over. So what happens? There will be lots and lots of migration of capillary endothelial cells from the existing blood vessels, from the existing capillaries. So this capillary endothelial cells, they migrate, they also take the genetic information where they know how to form a tube and they also migrate here. So along with this, now we need some more things here. There is the fibroblast growth factor. So fibroblast growth factor and vascular endothelial growth factor. So these are all released by the damaged endotheliums, alveolar endotheliums. So this alveolar endothelium, they are damaging this part, and there is the angiogenesis has started. Now this concept of neovascularization and angiogenesis is very important because new research are being doing on, because we know whenever there is any cancer cells that are multiplying, they need a lot of nutrition, and wherever a cancer cells or cancer is developing, there is a surrounding angiogenesis. So the research is being doing that if we can somehow we block this MMP when a cancer is developing, we can make the cancer cells starve to death. Okay, because without MMP there cannot be any angiogenesis, there cannot be any new blood vessels, and wherever you need some cells to grow, it's like a basic thing that you are making a new house and you need a water supply. So same thing here, when somewhere in our body there are some new things that are growing up, it needs a blood supply. So that is new angiogenesis. It should go side by side in any sort of development of any sort of new structure. So same thing here, in the whole process of interstitial lung disease, there is the upsetting of this balance. This is tissue inhibitor, metalloproteinase and metalloproteinase enzyme. As a result, there is angiogenesis or neovascularization is developed. So this balance upset is not only favoring the angiogenesis, it also making more and more fibroblast deposition. So now more and more fibroblasts are deposited. So now these fibroblasts, along with the blood vessels, they are doing, they have become a now myofibroblast. Now they have they become myofibroblast. So once a myofibroblast is formed, it's like a permanent or irreversible scarring. Now whole these things has become scarred. Okay, it has got a new blood vessels, it is getting whole supply of nutrition, and the whole thing is becoming like a scar tissue, what we call fibrosis. Okay, and what else can happen here? So you can see this, lots of endothelial epithelium is damaged, some growth factors are there, and from here also some neutrophils can migrate. Okay, from neutrophils can migrate, and they can also release some inflammatory factors. So there is a whole lot of inflammation here. The release of cytokines and a lot of inflammatory factors is coming in. So this inflammation is progressive, it's going on. Side by side scarring is going on. Side by side angiogenesis is going on. And together what is going? There is a deposition of here extracellular matrix. Okay. So deposition of extracellular matrix. There is deposition of extracellular matrix. So this, what's happened here, it leads to scarring of the tissues, or it leads to, together we call it a scarring, or this is we call fibrosis. So this thing is the pathophysiology of interstitial lung disease. So when you write the interstitial lung disease in the exam, you have to write in this manner. You write in this sequence that there is start of microinjury of epithelium, alveolar epitheliums. Then there is the antifibrinolytic environment leading to formation of multiple clots. So there is fibroblast migration and proliferation. Then formation of myofibroblasts. Side by side, you have to mention about the neovascularization that takes place because of imbalance between tissue inhibitor metalloproteinase and metalloproteinase. So because of this imbalance, there is more and more growth of fibroblasts and deposition here, plus there is angiogenesis. new vascularization or new blood vessels are formed to supply nutrition here. Plus there is, so this whole thing is happening because of release of some more factors, that is by alveolar epithelium, damaged alveolar epithelium like fibroblast growth factor and vascular endothelial growth factor. So this is the, in brief, this is the pathophysiology of interstitial lung disease. So if you know the pathophysiology of interstitial lung disease, now you see lots of new blood vessels are forming here. New blood vessels are forming soon. So these new blood vessels with damaged endothelium. So this is one factor that sometimes blood may ooze out and it can result in hemoptysis. So which is also one part of clinical feature of interstitial lung disease. So if we go for the clinical features of interstitial lung disease, so first thing you have to note it that here there is progressive, because this thing is slowly developing. So there will be progressive dyspnea, progressive dyspnea. Progressive dyspnea, you have to mention this word because interstitial lung disease is developing slowly, right? All these things are happening side by side. So there will be progressive dyspnea, there will be progressive, again, non-productive cough. Non-productive cough. So there is no secretion of mucus here. So it is not an obstructive lung disorder, there is secretion of mucus or there is some obstruction here. So there is a here, because of no obstruction here in the lumen of the airway tract, so and no production of mucus here, so obviously this cough will be, that cough will be present here, it will be non-productive. And there is progressive dyspnea. Now why there is dyspnea? The fact is that we need, our alveoli need a particular clear space so that during inflation it can inflate so that you can take that space. Now you are restricting that space, so inspiration cannot take place properly. So you cannot take air properly. If you cannot inhale properly because of restriction of the movement of alveoli, then there will be, obviously there will be a dyspnea. So progressive dyspnea, progressive non-productive cough with hemoptysis. These are the trademarks of interstitial lung disease. And on physical findings, there's one more thing you must add when you write in an exam paper, is that end-inspiratory crackles. Okay, so wait, let me write down here. It's end-inspiratory crackles. End-inspiratory crackles. Now why you call end-inspiratory? So you see, so these are the scar tissue that are formed, that are laid down in this space. Now, when this person, when he is inhaling, when he is trying to take air, this alveoli is becoming big. So when it is becoming big and finally it touches the layer of this scar tissue, then it will make a sound. Okay, when it is going big during, so at the end of inspiration, when it will touch this layer, it will make some crackles. It will make some sound which he calls crackles. So when you write in the exam, don't forget to mention it's end-inspiratory crackles. Okay, so end-inspiratory crackles, progressive dyspnea, non-productive cough, hemoptysis, they are all a common manifestation of interstitial lung disease. Now if we go to the spirometrical test, so what are the things in, what will happen to the FEB-FBC ratio? So what can happen in FEB-FBC ratio? Now, FBC ratio. Now, this space is restricted. So, will it be difficult for inspiration or will it be difficult more in expiration? So, we know that because of limited space available, inspiration will be difficult, yes. So, compliance will be decreased. But is the elasticity decreased? No, elasticity remains same, though it cannot expand. But there is no problem with the elasticity, like in cystic fibrosis or bronchiectasis or emphysema. There is no problem in elasticity here. So compliance decrease, but elasticity remains same. So during exhaling, so when we are trying to expire, when you're trying to experiment, alveolus are tending to become smaller in size, so there will be no problem in that. Okay, so FEV1 does not change. Okay, but FBC, because the total lung capacity, we are not able to take air in because of restriction of this space. So total lung capacity is decreased in the spirometrical test, and forced vital capacity, FBC, will significantly decreased. So as a result, this whole ratio, because the denominator has significantly reduced, as a result, this whole ratio, FEV1 FBC ratio, either it remains same or it is more than or equal to than 80%. So normal FEV1 FBC ratio, we know that is 80%. So in interstitial lung disease, it is usually same or does not change, or it is more than 80% because of significant reduction of FBC. And what other clinical features that will go with interstitial lung disease? Don't forget to mention about clubbing. So these are the basic clinical features that you'll find. Now when we do the classification, as I told you before, the interstitial lung disease classification, you'll find varieties of classification by many people. They have their own classification. But my request is, please don't write those classification in the exams. So when you have to write something, it must be from some standard textbook or some publications. Okay, it has to be reviewed. Okay, so you cannot write any classification from, you cannot pick any classification from some videos and you can write it down the exam paper. You cannot do that. Okay, you cannot get marks for that. So the best classification, when I did research in many textbooks like Davidson and other internal medicine textbooks, the best classification I got it is from the Harrison textbook. Okay. So in the Harrison textbook, the classification is mentioned at that. Now here, in interstitial lung disease, there can be sometimes either development of granuloma also. Granuloma can also develop. Now what is the granuloma? It is a surrounding of any bacteria. Suppose there is a bacteria, any bacteria or an antigen, and when this is surrounded by T lymphocytes and macrophages or phagocytes, then we call it granuloma. Okay. So in interstitial lung disease, these granulomas can also form, like for example sarcoidosis. And sarcoidosis is an interstitial lung disorder where there is granuloma is formed. While in pneumoconiosis, there is there is inflammation and scarring. So these two things can happen. So in Harrison, the diagnosis is made is like this, that there are two types of interstitial lung disease. So due to this interstitial lung disease, due to progressive inflammation and scarring, and inflammation due to granuloma formation. Now they have subdivided into known causes and unknown causes, known and unknown. So when you go for known causes, it is all the gas, fumes, okay, and asbestosis. So these are coming into the known causes, and particularly drugs. Now what drug that is most commonly come in MCQs and many other exams is amiodarone. And then radiation, chemotherapy drugs, gold. These are all known causes of inflammation and scarring. Unknown causes of inflammation and scarring, like idiopathic pulmonary fibrosis. Then idiopathic pulmonary fibrosis, as you know, this is and then some sort of amyloidosis. Then GI disorders, GI disorders like Crohn's disease, ulcerative colitis, and acute interstitial pneumonia. This comes to unknown classification. Now if we go to granuloma, the known cause are like hypersensitivity pneumonia, that is because of organic dust, and due to inorganic dust like silicosis, berylliosis, and unknown causes very commonly sarcoidosis. So this is the basic classification that I follow, and I insist that you also follow this type of classification, not from any other. Always follow a standard textbook when you are approaching some exam or you have to write those classifications in the exam. So that is about interstitial lung disease, and treatment is, you'll get varieties of treatment, but glucocorticoids remain the main line of treatment for interstitial lung disease. Along with glucocorticoid, cyclophosphamide are alternative way, but glucocorticoid is the mainstay of treatment of interstitial lung disease.